Hello, everyone. I'm Dr. Onyema Obuagu, and welcome to day two of this week's Crack the Case. If you haven't already viewed the day one video and answered the pre-polls, pause and please do so now using the links in the tweet below. This activity is jointly provided by National Jewish Health and Bonum CE. This program has been supported by an independent educational grant from Pfizer. Now, here's a quick recap of the case we presented yesterday. Yesterday, we presented a case of a 66-year-old Black woman who had tested positive for COVID-19 following onset of symptoms 3 days prior. Now, this woman has several risk factors for progression and the potential for more severe COVID-19 disease, such as age, race, and comorbidities, even though she is currently hemodynamically stable. Her COVID symptoms are mild, but she takes several medications, including amlodipine, apixaban, atorvastatin, dulaglutide, and over-the-counter naproxen for chronic medical conditions that could possibly interfere with her COVID-19 therapeutics. Now, Natasha, what do the NIH treatment guidelines recommend for patients like this?
NIH treatment guidelines recommend symptom management for non-hospitalized patients and antivirals for patients at risk for progression to severe disease. Antiviral therapy is recommended for patients who are at high risk for progression to severe COVID disease in this order of preference: Paxlovid, then remdesivir, and then molnupiravir. Given the co-formulation of nirmatrelvir with ritonavir as a pharmacokinetic booster, there is a potential for drug interactions, particularly with commonly used medications, including statins, calcium channel blockers, anti-epileptic agents, and CYP3A4 substrates. For most agents, dose adjustments or temporary cessation of a medication or clinical monitoring is all that is required during the 5 days of Paxlovid administration. For statins such as simvastatin or lovastatin, Paxlovid can be started 12 hours after the last statin dose, and then these medications can be held through about 2 to 3 days after completing Paxlovid dosing. While Paxlovid is the first choice and should be started within 5 days of symptom onset, we need to consider if it has interactions with any of these patients' current medications, which it does: apixaban and atorvastatin. Apixaban is a substrate of PGP and, like atorvastatin, is metabolized by CYP3A4. Concentrations of apixaban are expected to increase due to CYP3A4 and PGP inhibition by ritonavir. There is an option to use apixaban at a reduced dose of 2.5 milligrams twice per day while on ritonavir-boosted regimens, or she could be switched to a low molecular weight heparin or aspirin. Once treatment with Paxlovid is completed, the usual apixaban treatment dose can be resumed 3 days after the last dose of Paxlovid. Now, Paxlovid also interacts with atorvastatin. Given the short duration of Paxlovid, atorvastatin can be discontinued for 5 days of Paxlovid administration plus a 2 to 3 day washout period. The pragmatic approach to temporarily stopping atorvastatin or any other statin is acceptable, considering that it will not negatively affect the therapeutic effect, but can minimize the risk for adverse events related to a drug interaction. No interactions would be expected with dulaglutide and Paxlovid. If remdesivir is chosen, it has no interaction with dulaglutide. Remdesivir is also a weak inhibitor of CYP3A4, OAT-P1B1, and OAT-P1B3, bile acid export pump, multi-drug resistant associated protein 4, and sodium tarcholate cotransport protein. However, metabolism of remdesivir is believed to be mediated predominantly by hydrolases and not CYP enzymes. The short plasma half-life and need for IV administration that avoids hepatic first-pass metabolism likely results in low potential for drug-drug interactions. CYP3A4 inducers, such as rifampicin, can lead to decreased remdesivir levels, and it's recommended that these drugs should not be co-administered. However, remdesivir requires 3 continuous days of intravenous infusions and should be initiated within 7 days of symptom onset based on NIH guidelines. The requirements for IV infusion can be an issue for patients due to access and/or convenience issues. Molnupiravir should be initiated within 5 days of symptom onset and has no expected interactions with atorvastatin or apixaban. The pivotal clinical trial showed it reduced the rate of hospitalization or death from COVID-19 by 31% when compared with placebo. With all of this in mind, Onyema, what would you do for this patient?
Great question, Natasha. And I think you nicely went over the 3 antiviral options that we have available for this kind of patient. And, maybe I'll start with discussing some of the pros and cons and then mention what I would do in this scenario. Now, for Paxlovid specifically, it is an oral option and tablet. However, it does have the limitation of having significant drug-drug interactions, as you covered, specifically with the patient's apixaban and atorvastatin. Now, for remdesivir, while it's administered intravenously and so it's able to circumvent the drug-drug interactions, it's a shorter treatment course than Paxlovid because it's a 3-day dosing. However, we run into logistics issues with remdesivir regarding the logistics to administer remdesivir intravenously, which may be a challenge for different healthcare settings. And then the third option is molnupiravir, again, which is oral, limited drug-drug interactions, and no concomitant dose adjustments would be needed for this individual. However, we did see in the clinical trials that there appears to be lower clinical efficacy of molnupiravir in preventing the outcomes of hospitalization and death, composite outcome among individuals who were treated in the outpatient settings. And, in general, molnupiravir has been relegated to an alternative option if individuals cannot use Paxlovid or remdesivir, either to unavailability or they're not clinically appropriate or there are specific indications why patients are not able to use that. So in general, I tend to lean towards using Paxlovid. It's an oral option, easy to administer to patients. Now, for this patient, there would have to be concurrent medication adjustments, specifically for the statin, atorvastatin, as well as the anticoagulant apixaban. And depending on the indication for apixaban, the options may be to either use a lower dose or bridge with heparin during the period on which they'll be on Paxlovid and thereafter initiating when the Paxlovid has washed out. On the other hand, a drug like a statin can be held without significant consequences for a short period, allowing individuals to complete a course of Paxlovid before resuming it safely. So my selection for this patient would be Paxlovid. And don't forget, regardless of the provider preferences, we have to counsel the patient about their options and definitely engage in shared decision making on what therapeutic works for them and their situation.
Well, in this case, each of these options was discussed, and in shared decision making, the patient decided to go with Paxlovid and decrease her dose of apixaban and then temporarily discontinue the atorvastatin until she completed the course of therapy. She indicated a desire for the most effective therapy to return to health. Her clinical course was the patient was advised to monitor her blood pressure over the course of treatment, since elevated blood pressure can be a side effect of Paxlovid treatment. The Paxlovid was well tolerated by the patient, although she did report some slight nausea and a bitter taste in her mouth. She did check her blood pressure for the duration of treatment and didn't observe any major changes. The patient also reported no rebound or return of her COVID symptoms at her telehealth visit 8 days after completion of therapy. So the key takeaways from this case is that remote vaccination and low uptake of COVID boosters may result in waning immunity to COVID-19 variants. These individuals may need to be treated to prevent disease progression. And patients with risk factors for progression and the potential for more severe COVID disease, including factors like age, race, and comorbidities, they are eligible for antiviral therapy. And finally, drug-drug interactions with Paxlovid or other COVID therapies can be safely managed using recommendations from COVID drug interaction websites.
We'd like to thank you so much for joining us today. Please complete the post polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME. Click like and follow for more social media-based CME from Bonum CE.